All right, so just a quick update on the management of HIV positive patients who have a positive crack antigen, right? So what you're looking at now is the old protocol, right? So where it comes from is that whenever an HIV positive patient has a CD4 count less than 100, a crack antigen test needs to be done. The old protocol, once the crack antigen is positive, required us to check for symptoms. Then those who are asymptomatic will get the prophylaxis. Those who have a positive crack and they have symptoms would then be referred for treatment. So this particular first part of checking for symptoms, whilst still important to check for symptoms, it has now been changed. So let me then discuss with you the updated protocol, right? So remember that the Cryptococcus remains an important infection because it continues to cause a whole lot of morbidity and mortality. Most patients really who have a Cryptococcus meningitis are at a higher risk, of death. So in South Africa, we had introduced a program where we want to identify patients who might be having the crypto in the blood, but they're not yet in the CSF, so that we can treat that cryptococcus in the blood and prevent the meningitis, right? So how does it work? So if you have an HIV positive patient, you would do a CD4 count as part of your baseline tests. If the CD4 count comes back to be less than 100, right, then a crack antigen test in the blood serum, right, would be done. If that test is negative, then you don't have anything to worry about. You just continue your ARVs with the patient and deal with the other issues that might be there, right? However, if the crack antigen is positive, the previous protocol would say search for symptoms and decide based on symptoms. Now, our new protocol requires us to do a lumbar puncture, right? So all patients who have a positive crack antigen in the blood must get a lumbar puncture, right? If the lumbar puncture is done and it confirms that the crypto, in addition to being in the serum or the blood, is also in the CSF, that means now the patient has a meningitis. These patients would be admitted for at least 2 weeks, where they would be treated with two drugs, amphotericin B and fluconazole, 1,200 milligrams for 2 weeks, right? After 2 weeks, we would then stop the amphotericin B, reduce the fluconazole component of the treatment from 1,200 milligrams daily to 800 milligrams daily for 2 months, right? And whilst the patient is continuing with the 800 milligrams, once they conclude 4 to 6 weeks of antifungal therapy, we would then start them on ARVs, right? So don't forget to start ARVs. However, after 2 months, we can then reduce the fluconazole to 200 milligrams daily, continue the fluconazole for at least 1 year, and only stop it if the CD4 count increases to above 200 and the patient is virologically suppressed, right? So the orange phase there, the induction phase for the treatment wing would be done in a hospital and the patient would be admitted. Where you have done a lumbar puncture and the CSF results are negative, so the patient does have crypto in the blood, but the CSF is negative, we would then treat the patient with fluconazole 1,200 milligrams daily for 2 weeks. After 2 weeks, we reduce it to 800 milligrams for 2 months. And at the time where we reduce the fluconazole, we somehow start the patient on ARVs, whatever regimen that would be suitable for your patient. After 2 months of the 800 milligrams of fluconazole, we then reduce it to 200 milligrams daily for at least a year, and then discontinue this regimen when the CD4 count is more than 200 and the patient is virologically suppressed, right? So just to say a few things which are very important. At the time when you get your crack antigen, the patient might be on ARVs, right? So we don't recommend that you stop ARVs if the patient is already on ARVs. You'll have to monitor your patient and see if they are tolerating both. Where the patient is not doing well, then you may consider interrupting ARVs, at least until you have dealt with your crypto issues. The second part is that a lumbar puncture should not delay the start of fluconazole, right? Where you do not have access to a lumbar puncture or a doctor, or you're a rural clinic, right? You would start your patient with fluconazole 1,200 milligrams, then refer the patient to a hospital. But please, if you are working in a hospital, it is not ideal to treat crypto with one drug. It should always be treated with two drugs. The fluconazole 1,200 milligrams started at the time of diagnosing the crack in the blood. It's just supportive treatment, at least in transition, until your patient arrives at the hospital. To summarize the algorithm, you've got a positive crack in the blood. You need to check whether it's there in the CSF. A lumbar puncture is done. If it is done and it's positive, patient must be treated for 2 weeks in the hospital, discharged on fluconazole 800 milligrams daily for 2 months. After 2 months, reduced to 200 milligrams for at least a year. Only stop if the viral load is suppressed and the CD4 count is above 200. Where crack is positive in the blood but negative in the CSF, we call it the prophylaxis wing. This is the treatment wing. This is now the fluconazole prophylaxis path. We would start the patient on 1,200 milligrams daily of fluconazole, take it down to 800 milligrams for 2 months, then 200 milligrams for at least a year. Only stop if the CD4 count is more than 200 and the viral load is suppressed. All right, that is the updated algorithm. Please do your in-service trainings, share with colleagues so that we manage our patients correctly all the time. Thank you.